So good morning, everyone. I'll be speaking on our experience with retinal vein occlusions. So the most important risk factors when you see a patient is not just to treat the eye, but first investigate and look for these factors which need to be addressed: hypertension, diabetes, dyslipidemia, tobacco use. And in younger patients, more commonly is inflammation, which may be idiopathic or secondary to some of the diseases, homocystinemia, some malignancies, thrombophilia, and medication use, oral contraceptives, and sildenafil. So unless we look for these, we are doing great injustice to the patient because the actual problem is not solved. And in the eye, we need to be very vigilant about glaucoma in these patients because it's a very common comorbidity. And it may be responsible for the RVO in many cases. So look at the disc very carefully. It is easy to miss an early glaucomatous change or a notch. And once glaucoma is confirmed, avoid steroid injections for the macular edema because it can increase the IOP. And to treat the glaucoma, avoid drugs which can increase the macular edema being caused by RVO. Also, I have found in my work that severe papilledema can cause vein occlusions by compressing the vein from outside, apart from the internal occlusion which happens from the diabetes and hypertension. Papilledema compresses it from outside, adding to the problem. So RVO can be classified based on the location of the occlusion as central, hemiretinal, superior or inferior, and branch retinal, which can be one of the four. And these can be ischemic or non-ischemic. As well as the branch vein can be a major vein or a macular branch vein. Now, ischemic CRVO and HRVO are the worst in terms of prognosis. There is a drastic vision loss, extensive hemorrhages, and the vision remains poor even after the macular edema has resolved with injections because of the ischemia. The edema may not even be severe, but still the vision is not good due to the macular ischemia and requires extreme vigilance for neovascularization of the iris. Hemiretinal vein occlusions, only 2 quadrants being involved, still requires vigilance because relatively larger extent of involvement. So as I mentioned, extreme vigilance for iris new vessels. The highest risk used to be in the first 3 to 6 months earlier, but now the risk comes when anti-VEGF injections are stopped for the macular edema. So that could be even a year or 2 after the onset of disease. And non-ischemic cases are also not safe because they can progress to ischemic type in the natural history. So every case of CRVO and HRVO has to be counseled about reporting early symptoms of pain, redness, IOP rise. Non-ischemics have a better visual prognosis, respond with better visual acuity, fewer injections. Branch vein occlusion, the fundus can rapidly start looking normal, but there would be recurrent CME. The way to make a diagnosis might be looking at collaterals or the OCT angio, which shows capillary non-perfusion in the superficial and deep capillary plexus. Chronic CME can lead to epimacular membranes in the BRVO, macular hemorrhages, and over time, BRVO is also not harmless. It can present with vitreous hemorrhage, neovascularization of the disc, and these are asymptomatic cases. So they need annual review to be able to pick up proliferative retinopathy. Look carefully at the disc, very easy to miss neovascularization on the disc, and if this is seen, we can start the sector scatter laser. As in these patients, they are asymptomatic with minor vitreous hemorrhages. So annual review is extremely important. Even with this is a vitreous hemorrhage, where there is BRVO with the macular ischemia and new vessels. Macular branch vein occlusion at least does not have a risk of proliferative retinopathy, though it can have resistant macular edema, which is recurrent, and continues to show ischemia on the OCT with a hyperreflectivity of the inner retinal layers. It can also present with hard exudates if it's a chronically untreated macular branch vein occlusion. And the fundus picture can look completely normal in a macular vein occlusion very rapidly, but it can still get CME. So the best way to compare know whether it's a RVO is to compare the vessels with the other eye, where you can catch the minor tortuosity compared to fellow eye. You can see the collaterals, which may be very subtle, but OCT angio is very important to make the diagnosis. Fundus photography is very important even in the OCT era because it can pick up hard exudates which cannot be picked up by OCT. OCT can show, apart from edema, vitreoretinal interface changes, foveal thinning as a sign of prognosis, and external retinal layers disruption. OCT angio can show non-perfusion new vessels, but fluorescence is mandatory to identify macular leakage for macular laser. This is to show how a photograph can show us hard exudates which are resolving even when there is no CME. But we still treat to prevent the hard exudates from coming into the foveal center. Again, a patient with exudates which have increased because of 1 year of no treatment, no injections. And then as soon as we start injections, within 2 months, you can see the hard exudates have significantly resolved. So photographs are also very important, not just OCT. This is again a patient that was treated with 2 injections over 3 years. Now the OCT would show that there is no change, but the photograph shows that the exudates have resolved. So we have prevented exudates from coming into the foveal center. OCT, even if the edema goes away, the OCT continues to show the ischemia as hyperreflective area. OCT angio is very important to show collaterals, capillary dropouts, even neovascularization of the disc. I use it most commonly when there is a suspicion of NVD. And sometimes you can see an florid NVD on octa, which is not very clear on examination. FFA shows the leakage, which can be used to target the laser. And fluorescence also sometimes is useful in hazy media as in asteroid or vitreous hemorrhage, where octa is not useful to show the neovascularization on the retina or disc. It can also pick up sometimes new vessels on the iris as a massive leak, which was not otherwise detected on clinical exam. Treatment, of course, remains serial anti-VEGF injections. Laser or intravitreal steroids or vitrectomy remain only secondary options. There is a dramatic improvement with anti-VEGF injections, and this is the whole list available. Steroids can be triamcinolone or dexamethasone implant, but steroids continue to have side effects, so remain treatment of second choice after anti-VEGFs. So when to consider steroids? Only when anti-VEGF is contraindicated, as in pregnancy, cardiovascular events which are recent, severe renal dysfunction, or where traction may worsen with anti-VEGF. Do I have 1 more minute? Okay. So laser for BRVO has been shown to be useful, but now we use it only where patients continue to get several recurrences on injections. But we don't use it for every patient of BRVO, only when there are recurrences of macular edema. And this is a patient where patient did not want injection, and you can see that just laser has stabilized the patient with good 6/6 vision. Over 1.5 years, there is no injection given. However, for CRVO, there is no benefit to macular laser for macular edema. Every patient of RVO needs 6 to 12 monthly checkups, even if vision is good, for new vessels on the iris and on the fundus. And for more importantly, for fellow eye involvement, which is often very silent. You can see these are cases of bilateral RVO, and the fellow eye was silent. Lastly, CRVO can often come with ciliaretinal artery occlusion, so suspect this when vision is disproportionately poor to the macular edema. OCT angio can show, as you see in the picture, non-perfusion to confirm the ciliaretinal artery occlusion, and vision doesn't improve despite macular edema resolution with the anti-VEGF injection. And lastly, in the young, inflammation is usually the cause, which is mostly idiopathic, and the prognosis remains good. Many of them do not need an injection even, or a single injection generally suffices without requirement for repeat injections. Thank you.
Thank you, Dr. Mallika Goyal, for elaborate discussion on venous occlusions. Any questions, please? Dr. Ajay Arora.
So, Mallika, excellent talk. What I've seen is in some cases of BRVO, which is very mild, you don't get any change on octa in the superficial plexus, but you do have ischemia in the deep capillary plexus. So, I just wanted to, as a take home, that we must look at the DCP in these cases than only looking at SCP, because unfortunately in most of the machines you cannot measure FAZ in the DCP, you can only measure in the FA or in the superficial capillary plexus, but you can extrapolate by looking at serial images, and that tells us how this case is progressing. Another observation which I just wanted to say, You have mentioned about IVT and Ozurdex. We have been using suprachoroidal steroids in these cases. So by using suprachoroidal steroids, you are actually removing the complications which steroids cause in these cases, and yet get the same effect. So these cases are doing pretty well in our hands, and is working well.
Yeah, and cost efficacy would be great.
Cost efficacy, it's a complication
Yes.
of glaucoma or complications of cataract produced by steroids in these cases.
Yes.
Mallika, excellent photographs. Two comments and two questions actually. Comments were that there's no doubt that invasive FA in asteroid is better than non-invasive Octa, and laser for BRVO is a very good option. Questions were that treatment of a patient of RVO with hard exudates without macular edema for what?
Yes,
Because,
sir.
and treat with what?
Treat
Because if
with
there is
what?
no macular edema, still you want to treat hard exudates,
See,
apart
the-
from control of metabolic profile and those things.
Yeah, thank you, sir. Regarding the query about hard exudates, even if there is no macular edema, if the exudates you feel they are coming very close to the macular center, then I think it's better to prevent with a couple of injections and then take care of the lipid profile of the patient, hypertension, diabetes, of course. That is the only long-term management. But we need to get them out of the foveal center, because once they come there, later on when we inject, the exudate will go away, but the vision never returns to
No,
normal.
I agree. We do not want hard exudate to come
Yes.
to the center. But treat with what?
Treat with what? Okay. So I treat only with anti-VEGFs, sir. These newer anti-VEGFs, they are good enough. You don't need intravitreal steroids for that. There's no benefit, and in fact, we know the side effects. Most of these patients are phakic, so we don't want to create a problem. And IOP rise also, again, now we need to keep chasing the patient for IOP checks. So even if you say that it may last longer, which I don't think so, because with the newer
No,
anti-VEGFs, they last.
my doubt is that should we or should we not treat these patients? Because the thing is, aim is very good that we don't want hard exudate to come to center. But methodology of interval injection, that because we know these injections, whatever you may do, the migration is prevented primarily because of edema only. If there is a edema, you resolve it, hard exudate may go into center. But if there is no edema, then also you inject interval anti-VEGF.
Sir, I actually have patients, because of time I have not put many slides, especially DME, where also RVO, where there is no edema, but the hard exudates have progressed very badly. The fundus looks terrible over months because the patient refused injections. And so even without macular edema, they do not seem to follow the same course. We have patients where edema resolves but hard exudates increase. On the other hand, hard exudates resolve but edema continues to come back. So they do not seem to follow so hard exudates can worsen even without edema, it seems.
Thank you.
Thank you, sir.
Thank you, Dr. Mallika Goyal.